Good afternoon. I'm Captain Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Office of Emergency Risk Communication at the Centers for Disease Control and Prevention. I'd like to welcome you to today's COCA Call, New Clinical Tools and Resources to Support Patients with Prolonged Symptoms and Concerns about Lyme Disease. All participants joining us today are in listen-only mode. Free continuing education is offered for this webinar, and instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, all planners and presenters, moderators must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled product or products under investigational use. CDC, our planners and presenters, moderators wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from ineligible companies for this continuing education activity. At the conclusion of today's session, participants will be able to accomplish the following: describe the epidemiology and clinical presentation of Lyme disease, describe what is known about acute and prolonged symptoms associated with Lyme disease, and outline clinical approaches, tools, and resources for healthcare providers caring for patients with prolonged symptoms and concerns about Lyme disease. After the presentation, there will be a Q&A session. You may submit questions at any time during today's presentation. To ask a question, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note that we often receive many more questions than we can answer during our webinars. If you're a patient, please refer your questions to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to welcome our presenters for today's COCA Call. We're pleased to have with us Dr. Erica Kaufman-West, the Director of Infectious Diseases at the American Medical Association, and Commander Grace Marks, a medical officer in the Bacterial Diseases Branch in the Division of Vector-Borne Diseases at the Centers for Disease Control and Prevention. It's my pleasure to turn it over to Dr. Kaufman-West. Dr. Kaufman-West, please proceed.
Hi, thanks so much for the introduction, and thanks to everybody for joining us today. I'm Dr. Erica Kaufman-West, an infectious diseases physician. I am the Director of Infectious Diseases at the AMA, and I also maintain a clinical practice in Indiana. I'm really excited to be here today and share some information on a project that we've been working on for quite a while now. I'm going to start this call today by discussing the background for the AMA-CDC collaboration and the development of some educational products that's occurred through this collaboration. And my co-presenter today, Commander Grace Marks, will present the clinical approach when patients come to the office with prolonged symptoms and concerns about Lyme disease. Next slide. First, the AMA and CDC started a collaboration in 2021, and this was informed by AMA policy that actually developed and started a few years earlier. The AMA has always had a role in fighting clinical misinformation, and then at the 2019 annual meeting, the AMA House of Delegates adopted recommendations from its Council on Science and Public Health, noting that the threat posed by vector-borne diseases was increasing and that we have a limited capacity to respond. In addition, the AMA called for an increase in funding, research, and education for post-viral syndromes, such as long COVID. The AMA's goal is always to support physicians in their desire to provide the best care for patients. And this collaboration between the AMA and CDC starts and ends with that focus on providing physicians with the educational resources that they need to help patients. Next slide. I have just one slide on Lyme disease. Dr. Marks will go into much more detail on Lyme in her presentation, portion of the presentation. So just as an overview, so we're all on the same page, Lyme disease is caused by a spirochete, Borrelia burgdorferi, which is spread through the bite of an infected Ixodes tick. It causes 3 initial phases of disease. First is early localized disease, which typically manifests as erythema migrans, which is that bullseye rash that you've probably seen. Early disseminated disease can be characterized by cranial neuritis and heart block. And then there's late disseminated disease, of which monoarticular arthritis is the most common presentation. Now, the diagnosis and treatment at early stages of infection is important to prevent disseminated disease, which is more severe. Lyme disease is treatable with a short course of antibiotics. Next slide. After patients are treated, however, about 5 to 10% of them can continue to have prolonged symptoms. Because this is after treatment, the clinical name is post-treatment Lyme disease syndrome, or PTLDS. These symptoms are typically fatigue, joint and muscle pains, and difficulty concentrating. While the pathophysiology is unknown, multiple studies looking at long-term antibiotics versus placebo have not shown a lasting benefit. Next slide. Now, before we focus on those prolonged symptoms, I want to go through some of the terminology and history associated with Lyme disease. Lyme disease was first really reported around 1977, and that was after moms in Lyme, Connecticut, started to take note that their children were getting monoarthritis, and more so than their friends in other parts of the country. And the physicians, got this information and listened, and then they did more research into the potential causes, and that they found was, Lyme disease was identified as being caused by Borrelia. As they started to diagnose more Lyme disease, it became clear that some patients, again, about 5 to 10%, still had these prolonged symptoms despite having been treated. So to differentiate, initially, those first 3 phases that we talked about, those were called borreliosis, and that's still a common term in Europe. The term Lyme disease was used to refer to some of those vague and chronic symptoms that patients had after treatment. But that got a little confusing. So then a few years later, physicians and researchers coined the term post-treatment Lyme disease syndrome. Now, PTLDS was defined as having had a definite diagnosed Borrelia infection, having gotten appropriate treatment, but then still having symptoms several months later. And around this time, controversy began. There were some patients who never had that formal diagnosis of Lyme disease, and they started to ask why their symptoms, which were very similar to PTLDS symptoms, the fatigue, the body aches, the brain fog, why couldn't that also be from Lyme? And so at that point, the term chronic Lyme was sort of co-opted as a term to explain the illnesses that those patients were presenting with. Next slide. So that's the background of these terms and the why and the how of their use today. So there are hundreds of thousands of patients suffering from medically unexplained symptoms, and those patients are understandably concerned and looking for a diagnosis. Some of these patients wonder if Lyme disease might be the cause. Now, from the physician side, medically unexplained symptoms are really difficult to face. So physicians are traditionally trained in a biomedical model of education. So we learn about diseases, we learn about symptoms, we learn about the tests to diagnose those symptoms, and then the treatments once we have that diagnosis. So if a patient comes in to see me with a sore throat, swollen lymph nodes, and a fever, I sort of go through my Rolodex of medical information, and I can put together a differential list, right? Strep throat, mononucleosis from EBV or CMV, maybe acute HIV, and then I can do tests to rule things in or rule them out. So my worth and my place as a physician is really based on being able to take that list of symptoms and turn it into a diagnosable condition and then prescribe a treatment. Now, if a patient comes in with fatigue and body aches, I'm going to really struggle to put together what's probably going to be a very long list of possibilities. And then I'm going to struggle even more to find specific tests that can rule different things in or out. And I might not actually ever get to a diagnosable condition. So now I'm confronted with this possibility that I'm not a good doctor, that I don't have worth in this patient-doctor relationship. What am I doing here if I can't provide the patient with the service that they came to me for? And so that creates a tension now between the doctor and the patient. When really this failure of a diagnosis might be because current medical knowledge doesn't have a way to make that diagnosis yet. Next slide. In addition, the US healthcare system presents another challenge for these patients. So insurance reimbursement here in the US is for doing something, right? Tapping a joint, removing an appendix, swabbing a throat. It's not for thinking. It's not for searching the literature for 2 hours trying to figure out, a cause and effect. It's not for talking to the patient for 90 minutes and making that additional phone call after the appointment's ended to say, hey, I thought about this, or did you ever visit there? And then it's not, also doesn't reimburse us for making multiple calls to different healthcare providers to say, hey, I referred this patient to you. Let's talk about what you thought. Let's talk about what we can do next. It's also frustrating for patients as well because they get smashed into these 15-minute appointment slots that clearly their presentation and their symptoms need much more time than that. Insurance networks can also limit what physicians want to prescribe or where we can refer patients. So if there's a particular neurologist that I think is going to be really helpful, that I've worked with before, that I think has a great handle on this particular symptom, if that neurologist is not in network, well, now I have to either try to establish another relationship with a different neurologist, or now the patient's facing out-of-pocket costs. And maybe the insurance will only pay for a certain number of therapy sessions, for example, when really the patient might need a longer course if they're slower to respond. In some areas, just geographically, it's limited. There are limited specialists that live there. I worked in Southern Illinois for a while and was the only infectious disease doctor for a 60-mile radius for a couple of years. And so sometimes there's just no access to specialists depending on where patients live. And then social media, as we all know, can really reinforce misinformation, whether it's about Lyme disease or other infection-associated chronic illnesses. And all of these challenges can lead to what's called medical wandering. Now, medical wandering is when patients move from clinician to clinician and office to office, really looking for someone to connect with and build that medical home. Next slide. So now that we've touched on some of the frustrations that both the physicians and the patients have when patients present with these prolonged symptoms, now I'd like to, and we've touched briefly on the challenges of that biomedical model, the way in which physicians are taught and throughout medical school. We also have discussed about how the physician-patient relationship is deemed successful when the physician establishes that definable diagnosis. And this slide highlights this challenge in another way. So multiple studies over the past 30 years have looked at patients referred to academic centers for evaluation of chronic Lyme disease, and then they describe the final diagnoses that each of these patients received. Each column in this figure represents data from one of these particular studies. And each of these colors represents what the patients were ultimately diagnosed with. So as you can see in the green, about 20% of patients came in with symptoms. The physician looked at the patient, listened to the symptoms, looked at the patient's history and said, you know what? This could be Lyme disease, did the appropriate testing, and sure enough, they were diagnosed with Lyme disease and given appropriate antibiotics. The purple bars, those are patients that were diagnosed with PTLDS, which, as you can see across the board, averages about 5 to 10%, like I mentioned earlier. The blue lines represent patients where another diagnosis was found. So maybe they came in with symptoms and physician might have diagnosed, let's say, lupus or multiple sclerosis or major depressive disorder. So the patient came in wondering if this could be Lyme disease and was sent out with another diagnosis. Now, the last part, these gray bars here, these are patients where no diagnosis was ever found. And that's a sizable chunk, 30% or more, 40% or so of patients that never got an actual diagnosis. Next slide. So patients with unexplained symptoms may have a post-acute infection syndrome. And there's multiple terms that we're using, post-acute infection syndrome, as this slide shows. Another term is infection-associated chronic illness, or IACI. That's a little easier to say, so I'm going to stick with IACI. And there are many infections that can cause IACIs, and you can see here on the right side that Borrelia is just one of them. And then on the left-hand side, we have a bunch of viral pathogens that you can see that you're probably familiar with. So there's post-polio syndrome. Obviously, long COVID is in the research arena now. But there are also other ones where there's no name. EBV and West Nile can cause IACIs, and there's no way for us to test to distinguish between, are the symptoms that my patient is having now from an EBV infection they had, or is it from long COVID, or is it from Lyme? It's hard to dig back and find out what was that actual, the etiology of these post-infection symptoms. Next slide. So post-treatment Lyme disease syndrome and other IACIs share similar symptoms. So fatigue, the pain, cognitive impairment that we've talked about. So these similar symptomatologies beg the question of whether a similar pathogenesis is at play. And some theories have been proposed, and some of them are listed here. So one is natural variation. Perhaps some people take 2 weeks to get over an infection and some people take 2 years. And there's maybe not a good understanding of why, but maybe people just respond differently to infections. Autoimmunity or immune dysregulation. So an infection that might cause that immune system to sort of fire up and just stay fired up for no good reason. Maybe there's a persistent infection or a persistently retained antigen that's causing that immune system to stay on fire. There's just a lot of research going on into this space, and probably a lot more theories than I've been able to list on this slide. Next slide. I'd like to pause here and do a self-knowledge check. So the question is, which of the following statements are true regarding post-treatment Lyme disease syndrome? A, it affects about 5 to 10% of people diagnosed and treated for Lyme disease. B, the common symptoms include fatigue, body aches, and difficulty concentrating. C, it's best treated with prolonged courses of antibiotics. D, answers A and B. Or E, all of the above. I'll give you a couple seconds to consider. Next slide. The correct answer is D, which was A and B. So multiple studies have shown that after treatment for Lyme disease, about 5 to 10% of people will have these prolonged symptoms. The main symptoms, as we've discussed, fatigue, joint and muscle pains, and difficulty concentrating. And while the pathophysiology is not known, multiple studies looking at long-term antibiotics versus placebo have not shown a lasting benefit to the antibiotics. Next slide. So despite, or maybe because we don't have that pathophysiology sorted out, there are no evidence-based consensus or guidance to help physicians in how to provide comprehensive treatment to these patients that they're seeing. So with the CDC, the AMA embarked on a project to understand what clinicians need to provide care to patients with prolonged symptoms. Next slide. We wanted to hear from physicians who see complex patients, and we wanted to know what works for them, what doesn't work for them, what resources do they find helpful, and what resources do they wish they had. So we partnered with Mathematica, a company that specializes in providing qualitative medical research. Next slide. The objective of this work with Mathematica was to collect suggestions and ideas from physicians who care for patients referred for chronic Lyme disease to help other physicians improve their care for patients with similar concerns. So Mathematica conducted 4 interviews and 4 focus groups in the summer between June and July 2022, with a total of 25 experienced physicians. Next slide. Included were attending physicians from a few different specialties, which I've listed here: primary care, neurology, psychiatry, rheumatology, and infectious diseases. These physicians did not focus exclusively on Lyme disease. They treated a wide variety of conditions, but they did see 5 to 30% of patients per year specifically for concerns about Lyme disease. Next slide. 3 themes emerged from these discussions and interviews. And the first, which was almost universal, was a need to validate patients' symptoms and let the patients know that they are heard. What the physicians told us was that many patients that they see expressed feeling rejected by physicians and the medical establishment as a whole. So they really focused on the fact that a key component of their providing care was connecting with the patients, saying things like, I hear what you're saying, really showing that there was a connection and that the patient was being listened to. The second theme was that these visits take a lot of time and they can be overwhelming and emotionally exhausting. And part of this, I think, is because of that tension with the biomedical model and the physicians really feeling that deep desire and need to provide a diagnosis. And third, there was a lot of overlap with other syndromes like fibromyalgia, chronic fatigue syndrome, and even long COVID, and navigating between these different possible diagnoses was difficult. Next slide. Education is one of the AMA's strategic priorities and is closely aligned to our mission. In November 2022, the findings of these focus groups and interviews were shared in an educational session at the AMA's interim meeting. There was an AMA news story highlighting this session, and it was posted on the AMA's website. It continues to get around 500 views per month, so we know that this is a topic that's important to physicians. Then we got to work developing a CME module, and we also developed a toolkit to guide physicians in how to provide empathetic care for patients with prolonged symptoms. And lastly, using the findings from the focus groups and the interviews, we are developing a manuscript to share what these physicians found most helpful in caring for these patients. I'd like to share a little more about the module and the toolkit with you today. Next slide. The module is hosted on the AMA EdHub and provides 1 category credit of CME. While there's a small section on Lyme disease, just for a general overview, it really focuses on providing care for patients with prolonged symptoms. It goes through how to create a broad differential diagnosis, how to compile a multidisciplinary team, and how to work with the patient and team members to create an individualized care plan. Next slide. The toolkit lives on the AMA website and includes resources for both physicians and patients. So the QR code is at the top right of your screen for you to access directly. It includes the CME module that I mentioned, along with interviews and videos, some supplemental handouts. And what I'll do in the next couple slides is go through some of those supplements that we've put together. Next slide. So we have videos with experts such as Camille Kroll, who's currently a doctoral student specializing in medical anthropology. She goes through the pitfalls of relying solely on the biomedical model when working with patients. And this was really just, for me, eye-opening to hear from her sort of the background in the sociology of making a diagnosis and working with patients that don't have that definable diagnosis. I found it just fascinating. There's a whole bunch of literature out there that, for me as a clinician, was brand new and really opened my eyes to how I approach patients with these complex symptoms. And then Dr. Paul Auerwater provides a great update on the epidemiology of Lyme disease. There's also a 1-hour webinar with Dr. Marks and myself explaining many of the concepts that we're touching on today. Next slide. We have several handouts that are made for clinicians to give their patients. So the one on the left is a symptom diary. And the way that we have structured this is that the first page sort of explains how it might work. And you'll see that picture on the left is the first page. The second page would just be blank, and then the patient would be able to fill that out. And this helps provide an objective way to look at the symptoms. What makes them better? What makes them worse? How different interventions affect the symptom? I think that it's kind of unfair to ask patients to recall, what happened 1.5 months ago when you tried that medication for 3 days. I mean, I don't remember what I had for lunch 2 days ago. And then asking patients to recall specific details about, how they woke up in the morning or what they felt like when they went to bed is a little bit unfair. So this allows the patient to track in real time how they're doing, empower them to put their responses to treatment into their own words, and then come back to the clinician and say, hey, this is how I felt on those days. On the right-hand side is a goal tracker. So we as physicians should not be making assumptions about the patient's goals. So maybe it's getting through the workday without taking a nap at lunch. Maybe it's walking around the whole grocery store doing their entire shopping in one trip. These should be very specific goals, not just I want to feel better, but actual, measurable goals. And then the physician can help guide that discussion, but really the patient needs to be the one making that final declaration about what their goals are and what's important to them. And then together, the physician and the patient can talk about specific action steps, maybe what challenges they might face, so that the patient can develop some confidence and a plan about how to face those challenges when they come. Next slide. We also have several handouts geared at clinicians, and these are a couple of them. So motivational interviewing is really helpful to understand why patients, why they might want a specific treatment or a certain test. It also helps the physician to stay patient-focused when you dig deeper into the issue. And again, this is really that art of listening, of asking a question and then stopping and listening to what the patient's saying. Then there's also a guide on how to discuss topics where the physician might think one way is better and then the patient might think another way, and you start to have that tension. So this is a way to maybe help diffuse some of those situations and again, really turn and focus on the patient. There's also a sample referral letter that you can send to other healthcare professionals just to understand what the expectations are when you invite them to join the care team. Next slide. So the toolkit is live, as I said, and we're really excited to share it with you all. We got a lot of feedback from a wide variety of physicians, and we hope you find it helpful as you care for patients with prolonged symptoms and concerns about Lyme disease. We're going to continue to work with professional organizations to really reach frontline clinicians who can use this toolkit. We're for example, the American Academy of Physical Medicine and Rehabilitation is one of the leaders, if not the leader, in long COVID guidance. And their mission to really help physicians provide care for patients with symptoms after COVID runs really parallel with our goal to provide that same sort of empathetic care for patients with prolonged symptoms and concerns about Lyme. At this time, I'd like to turn it over to Dr. Grace Marks.
Thank you, Dr. Kaufman-West. I'm very happy to have the opportunity to be presenting with you today. So as mentioned, I'm Commander Grace Marks, an infectious disease physician and medical epidemiologist with CDC's Division of Vector-Borne Diseases. And today I'll be discussing a clinical approach for caring for patients with prolonged symptoms and concerns about Lyme disease. Next slide. So this approach is really based on the work that we at CDC did in collaboration with the AMA and Mathematica to identify best practices based on focus group discussions and interviews with clinical experts. The toolkit that AMA developed covers this approach in detail, but I'll outline the general principles here today. So in these clinical encounters, it's important to take a really systematic approach to the patient evaluation. As Dr. Kaufman-West mentioned, it's I can't overemphasize the importance of how critical it is to actively listen to the patient's story. And that includes really thoroughly exploring the patient's timeline of their symptoms, as well as their response to any prior treatments that they might have tried or been prescribed. And this should really, of course, go without saying, but be sure to conduct a comprehensive physical examination for these patients. Yeah, I think that's just really kind of central to developing rapport. And as Dr. Kaufman-West also mentioned, most of these patients will ultimately be diagnosed with a condition other than Lyme disease. So it's really important not to anchor prematurely to a particular diagnosis. Rather, systematically consider a broad differential diagnosis that is specifically tailored to the patient's symptoms and also their exam findings. The reasons for that a patient may be concerned about Lyme disease are incredibly diverse. And so take the time to ask, why these concerns about Lyme disease? And also take time to answer any questions that they have about Lyme disease. It's an opportunity to provide education about Lyme disease during each of these clinical encounters, but you won't know what to address unless you really ask what the questions are. Consider whether testing for Lyme disease using two-step serologic testing with an FDA-cleared assay would be helpful, and whether treatment for Lyme disease would be indicated. And finally, building a multidisciplinary team that's coordinated by the primary care clinician can be very helpful to address specific patient concerns while also supporting optimal patient health and recovery. Next slide. As mentioned, considering a broad differential diagnosis during these encounters is critical and needs to take into consideration the patient's symptoms, their physical exam, but also individual risk factors. And as we'll talk about later, where they live, where they visit, and what they do. Some conditions to consider are listed on the slide, but it's definitely not a comprehensive list. Next slide. So as was mentioned before, chronic Lyme disease is really so much more than a medical issue. It's a social phenomenon that's driven by a combination of patient desperation for answers, physician frustration, and also medical misinformation. And so as the physician, bringing a solid science-based understanding of Lyme disease to these clinical encounters is very important. So in order to effectively address a patient's concerns about Lyme disease, it's obviously important to have a solid evidence-based understanding of the disease. A comprehensive clinical overview of Lyme disease is outside the scope of this presentation, but there are many excellent clinical resources that review Lyme disease in detail. A few of those resources are listed here and include an online clinical educational series that CDC developed, and that also offers continuing educational credits. The NAPNAP Knows Lyme website, which provides resources that are tailored to the pediatric clinical setting. And some of those resources include a provider pocket guide about Lyme disease and also patient handouts. And there's also the Joint Professional Guidelines on Lyme disease, which provides specific guidance that addresses common clinical scenarios. And those links are included on the slide here. Next slide. For laboratory diagnosis of Lyme disease, CDC recommends a two-step process using FDA-cleared serologic tests that detect specific antibodies to the Lyme disease spirochete. So in general, this is a very good test for Lyme disease. However, sensitivity can be low in very early disease prior to when antibodies might have yet developed. And so it's important to know that a positive serologic test for Lyme disease does not necessarily indicate active infection. So this test again detects antibodies, and those can remain present in the body for years despite effective treatment. As a serologic test, cross-reactivity can also occur to antibodies of other similar pathogens, such as to other Borrelia species, including those that cause tick-borne relapsing fever. It's important to know that there are some laboratories that offer Lyme disease testing that has been developed in-house and has not been FDA cleared, and therefore whose clinical validity is unknown. So it's important that your patients really only be tested for Lyme disease using FDA cleared tests. The Association of Public Health Laboratories, APHL, also provides a very helpful provider interpretation for serologic test results for Lyme disease, and you can find a direct link using the QR code at the bottom right of this slide. Next slide, please. The decision about whether to test your patient for Lyme disease should be informed by their pretest probability of having the disease, which is determined both by the probability that they might have been exposed to infected ticks and also by their clinical presentation. So the first clinical question that informs pretest probability of Lyme disease is whether the patient has spent time in an area where Lyme disease is common. Ask your patients where they've lived, but also where they have visited. As you can see in the map on the bottom right of the slide, there are 15 states in the Northwest, or excuse me, Northeast, Mid-Atlantic, and Midwest that are highlighted in yellow, and those show the states where incidence of Lyme disease is high. The hatched lines on the map indicate areas with some local transmission of Lyme disease, and the rest of the U.S., which is in that dark green color, indicates areas with low or no local transmission of Lyme disease. Next slide. The second question that informs pretest probability of Lyme disease is whether the patient was likely exposed to ticks. And this requires asking the patient about their behaviors, such as do they spend time outside in tick habitat? Do they work outside? Thinking about occupational exposures. What do they do for fun, such as gardening, hiking? But remember, it's also just simply spending time in the backyard that could be a risk factor for a tick bite. Next slide. It's also helpful to think about when ticks are active in your area. As one option is you can check out CDC's tick bite data tracker, and you can scan the QR code there on the bottom left of your slide, and that'll show emergency department visits for tick bites in the United States. A screenshot of one of the diagrams is shown there on the bottom right of the slide, and you can see it shows ER visits for tick bites by month. And you'll see two distinct peaks, and by far the highest peak of tick bites occurs in the late spring and summer, and there's also a smaller peak in October and November. Remember that, so these are just emergency department visits for any tick bite. So it's not just bites by the Ixodes scapularis tick that transmits the majority of Lyme disease, but it is also helpful to just know when ticks are biting in your region of the United States. Next slide. The third clinical question that informs pretest probability of Lyme disease is whether the patient has symptoms characteristic of Lyme disease. So some examples that Dr. Kaufman-West mentioned earlier include erythema migrans, facial palsy, meningitis, carditis, most commonly presenting as heart block, and also acute monoarticular arthritis, typically of a large joint. Remember that nonspecific symptoms such as low-grade fever, myalgias, arthralgias, and headache are often present in early disease. And so when patients present in the summer, again, when those ticks are most active, with those symptoms after the patient's been in an area where Lyme disease is common, you should really be thinking about Lyme disease and by extension, other tick-borne diseases as well. Next slide. I'll take a brief pause here to share a knowledge check. And the question is, what are patient characteristics that contribute to their pretest probability of having Lyme disease? Answer option A is spending time in a geographic area where Lyme disease is common. Option B, spending time outdoors in tick habitat. Option C, having symptoms characteristic of Lyme disease. Option D, having concerns about Lyme disease. Option E, answers A, B, and C only. And option F, all of the above. Next slide. The correct answer is E, which included the answer options A, B, and C. And the reason for this is because patients are more likely to have Lyme disease if they've spent time outside in an area where Lyme disease is common. Again, if they spend time outdoors where they could get bitten by an infected tick, and also if they have symptoms that are characteristic of Lyme disease. Next slide. I very briefly touched on this before, but I think it's worth mentioning again the Joint Medical Professional Society Lyme Disease Guidelines. Authors included physicians from the Infectious Diseases Society of America, the American College of Rheumatology, and the American Academy of Neurology. These guidelines are really comprehensive. They're evidence-based, and they provide a basis for the prevention, diagnosis, and treatment of Lyme disease. And they're also just a really practical resource for practicing clinicians. They use a question-based approach and address common clinical questions that you might encounter when you see patients regarding Lyme disease. As was mentioned, the recommended antibiotic treatment duration is 10 days to 4 weeks, depending on the clinical manifestation. And importantly, these guidelines recommend against additional antibiotic therapy for patients with prolonged symptoms following treatment due to lack of proven sustained benefit compared to placebo. Next slide. Not every patient with prolonged symptoms and concerns about Lyme disease needs an automatic consult to an infectious disease physician. Very often, the primary care provider can adequately address a patient's concerns and send testing or order treatment as appropriate. But sometimes when there's a specific clinical question or when a patient needs additional help to manage certain symptoms, a referral to the appropriate specialist can be helpful. To ensure that patients continue to receive coordinated care within their medical home, communication ideally is between the primary care provider and any specialist, and that communication should be clear and involve a follow-up plan back to their PCP. The AMA toolkit includes an example referral letter, and this can be downloaded and also tailored to your patient's specific situation. Next slide. So when I see a patient in clinic who has prolonged symptoms and concerns about Lyme disease, I often find that it's helpful to remember these key considerations. First, patients with prolonged symptoms are ill, and some of them have been ill for a long time, and many are quite disabled and often desperate for answers and help. Recognizing suffering and validating your patient's lived experience can really be a powerful way to not only provide emotional support, but it can also establish a foundation for a therapeutic relationship. While we know from clinical studies that prolonged courses of antibiotics do not offer lasting benefit over placebo, we unfortunately still don't have much guidance on what does help these patients. And so currently management should be tailored to the individual patient, using evidence-based approaches and guided by the principle of to first do no harm. Maintaining diagnostic humility is key. As medical providers, we just don't have all the answers, and the state of current medical knowledge is limited. It's incomplete, and I think we should really recognize that. Many patients with prolonged symptoms and concerns about Lyme disease, as Dr. Kaufman-West mentioned, report feeling dismissed by mainstream providers and that their illness is not taken seriously. And as a result, patients may develop medical wandering, possibly turning to alternate providers who recommend unproven and sometimes even dangerous treatments. Rather than turning patients away, I would encourage you to really welcome these patients into your practice, recognizing that each clinical encounter is an opportunity to provide support and encouragement for patients who are looking for help. We know that misinformation about Lyme disease is common in the general public and in online spaces, and this can be very confusing to both patients and providers. So help your patients to identify trusted sources of information. Next slide. So in summary, these clinical principles listed here, I think can really help clinicians provide excellent care for patients with prolonged symptoms and concerns about Lyme disease. Most importantly, take the time to really hear your patient. View each patient visit as an opportunity, not only to educate about Lyme disease, but also to learn from your patients. Follow evidence-based guidance for the diagnosis and treatment of Lyme disease. And consider using resources in the AMA toolkit that are tailored to your patient's specific concerns and needs. And finally, always ensure that your patient has a follow-up plan to facilitate continued engagement in care and so that their needs can ultimately be adequately addressed. Thank you. Next slide.
Presenters, thank you so much for providing this timely information to our audience. We will now go into our Q&A session. Joining us for the Q&A session, in addition to our presenters, are Dr. Allison Hinckley, lead of the Epidemiology and Surveillance team, Dr. Christina Nelson, medical officer, and Dr. Paul Mead, who's the branch chief of the Bacterial Diseases branch. So for our first question, we've received multiple questions regarding the toolkit that Dr. Kaufman-West shared information on. Our first question asks, can you clarify if this toolkit is available for providers to use who are not members of AMA?
Thank you for that question, and my apologies for not including it in my talk. Both the CME module and the toolkit, as well as all the videos and access to the supplements, are absolutely free to non-members. You do not need to be a member to access those. If you want to do the CME module for credit, you have to create an account, which is free, but you don't have to pay for a membership to have access to either the module or the toolkit.
Thank you very much for that clarification. And for our audience, I would like to remind you that you can go to this COCA Call's webpage at emergency.cdc.gov/COCA, click on additional resources, and there's a link that will take you directly to the toolkit. And I'll share that link again towards the end. Our follow-up question on the toolkit: can this toolkit be used for children and adolescents?
This is Dr. Erica Kaufman-West. I'll answer that. Yes, so this toolkit was designed to be applicable to all patients who present with prolonged symptoms, irrespective of age. For pediatric patients, obviously we would recommend a pediatric-centered approach, so you have to bring in parents or other caregivers into the discussion. The physician or clinician might need to adjust some of the supplements in the toolkits and have the parents, for example, fill out the symptom diary or goal tracker, especially with younger children. But older children, though, I think could be encouraged to take a larger role and have a louder voice. Now, it's a delicate balance that pediatricians have always walked gracefully, and this would be no exception. Obviously, working with pediatric specialists when possible would be great. As mentioned briefly during the webinar, there are several pediatric-focused resources available, one at the napnapknowslyme.org website, and then also the American Academy of Pediatrics.
Thank you very much. Our next question is generally around the topic of the rash, its presentation, the various ways it can present, the absence, the presence, and how to determine treatment based on either of those situations with the rash. So I would like to invite the panelists and the presenters to please speak a little bit about that issue. Thank you.
Yeah, sure. I can jump in here. This is Dr. Grace Marks. So the rash of Lyme disease, erythema migrans, is typically present in early localized Lyme disease. So about 80% of folks or more typically get this EM rash at the site of a tick bite. It's a fairly unique rash, but it's not pathognomonic. So, you have to be thinking about other things in addition to Lyme, but the typical presentation is that it's kind of a large area that's red. Typically, it doesn't itch, it doesn't hurt. It can be slightly indurated. And again, this is at the location where that tick attached. And it gradually expands over a number of days, and typically gets quite large, 5 centimeters or more. And then if it's not identified, so often, it might happen, on the scalp, maybe behind the behind the leg or on the back, somewhere where you don't see it. So it's not uncommon for it just to be missed. And it will kind of resolve on its own, even without treatment. But then, as was mentioned, there is the risk that the spirochete will disseminate to other parts of the body. And early disseminated Lyme disease also includes a rash. This is typically a multiple erythema migrans rashes. And these are typically a little bit smaller, but not necessarily at the site of the tick bites. These are kind of in different areas of the body. And again, just kind of this erythematous patch. The bullseye kind of appearance is often mentioned. That can happen. It's maybe not even the most common appearance. They can really look quite different. And so sometimes they're round, sometimes they're oval, sometimes they're not. Sometimes, depending on the skin tone, they can appear like almost like a bruise. So really having an open mind and keeping Lyme in the differential, if you have a patient who's been in an area where Lyme disease is common, is really important. Just touching on the question about treatment. So typically for treatment of erythema migrans, you're looking at a 10-day course of doxycycline, a 14-day course of amoxicillin, and that's for either just a single EM rash or multiple EM. And again, typically you'll have full resolution after that short treatment course. Would any of the other panelists like to add anything to that?
I think you covered that, Dr. Marks.
Great, thank you so much. Our next question asks, some of the symptoms that you've discussed for PTLDS are similar to those experienced by patients with long COVID. That's sort of the new paradigm we find ourselves in. So what is the best approach for providers to differentiate between long COVID and long-term sequelae of Lyme disease?
I can take that one. This is Dr. Kaufman-West again. So you're right. As we discussed, there is an overlap between a lot of infection-associated chronic illnesses. And we know that nowadays, 4 years after this, the pandemic has started, that the background rates of COVID serologic positivity are very high. So testing someone for COVID is probably not going to change anyone's management. And a diagnosis of long COVID doesn't actually require serologic testing for SARS-CoV-2. So trying to do testing for COVID it's not going to be helpful. And I think this brings us back to what Dr. Marks said about really making a broad differential diagnosis. So if the patient's symptoms and history are consistent with late disseminated Lyme, then serologic testing with that 2-step FDA cleared test would be important to do. And so a positive result can be helpful and might help you consider, that 2 to 4 week course of antibiotics, depending on the symptoms. But it's also important to rule out other diseases that might have a clear treatment course, like, cancer or lupus or whatever fits into that patient's symptomatology. And ultimately, this toolkit is relevant for clinicians who are caring for any patient with prolonged symptoms, not just those that specifically come in asking about Lyme. So the goal of the toolkit is obviously to improve the lives of these patients, no matter the cause. And I think that's part of what we would like to stress, is that it doesn't, like, trying to hunt back for what caused it. In infectious diseases, we have people that come in very sick with sepsis, and we might never actually discover what was the etiology of that intense inflammatory response to an infection. The goal is to meet the patient where they are and walk them through until they feel better. And so that I understand inherently that need to say, well, why did this happen? Why did this happen to me? But sometimes we're not able to answer that, and that's okay. And I think, and helping patients understand that that's okay, and really focusing on what are the symptoms, what can we start treatment for? And so trying to change our mindset as clinicians from, let me make a diagnosis for this patient, but rather saying, let me help this patient reach what their healthcare goal is. So is it to have less pain? Is it to have fewer headaches? Is it to improve their fatigue score? And so it's not about, keeping these patients in our care so that we can get to a diagnosis. It's about saying, you've got pain. How can we get you better pain, less pain days? How can we have better quality of life days, and not how can we get to a diagnosis? So once you've gone through your differential and you've ruled things out, then we get to that point of, okay, let's look at how we can work together and what's being helpful, what's not helpful, and really trying to partner with the patient. And that connection and that care is what's going to keep them coming back, and establishing that medical home with you as a primary care physician.
Thank you very much. We have time for one more question, and we should consider answering this question that we've received in multiple forms about the need to perhaps extend treatment or warrant another full month of treatment after 2 weeks of treatment with doxycycline. So I was hoping the presenters could globally talk about these issues.
Yeah, maybe I can start, and I'd welcome input from other panelists as well. This is Dr. Grace Marks, and it's a good question, and one that frequently comes up during these clinical encounters. I will say, I think the decision about whether to treat with an additional course of antibiotics depends on a lot of different factors. And so it's kind of hard to go through all of them here, because it needs to be taken on a case-by-case basis. And ultimately, what you're doing as a clinician is you're weighing the risks of potentially unnecessary antibiotics and thinking about potential harms related with those against the potential benefit of an additional antibiotic course. The current 2020 guidelines for the treatment of Lyme disease do suggest that in some situations, particularly in the context of that late disseminated form of Lyme disease, so typically monoarticular arthritis of a large joint. Sometimes that does, symptoms of, arthritis, swelling at that joint, pain at that joint, do continue after a full 4-week course. And maybe there would be benefit from an additional 4 weeks of antibiotics. But that is really kind of more the exception than the rule. So again, I think you really do need to be thinking through the patient in front of you and kind of making that judgment call. I will say that, doxycycline, especially kind of a short course of 10 days or a couple more weeks, is probably fairly benign. We're getting more and more used to using doxycycline with, PEP to prevent STDs and other sorts of things. And we know that it's probably fairly benign. Of course, there's some risk for GI discomfort and, sun toxicity. It's certainly less risky than a lot of alternative therapies that may be used, such as chelation or heavy metal therapy, or even nutritional therapy sometimes. Stem cell transplantation has been suggested as an option for some of these patients, and we do not endorse any of that. Again, the risks of potential harm there are very high. And so you're really, again, just weighing the risks and the benefits as a clinician, but really making that decision on an individual case-by-case basis. Any other of the panelists, though, any other thoughts there?
Okay, well, this concludes our session, and I want to thank everyone for joining us today. With a special thanks to our presenters and our experts. This year, CDC is moving from the training and continuing education online system that provides access to CDC educational activities for continuing education to CDC Train. If you do not already have a Train account, please create one at www.train.org/CDC Train. All new activities that offer continuing education from CDC will only be listed in CDC Train. CDC Train is a gateway to the Train Learning Network, most comprehensive catalog of shared public health training opportunities. This transition will allow you to access non-credit and for-credit educational activities, track your learning, including CE, in one place. Many CDC-accredited activities are listed in CDC Train. The move to one system improves efficiency and makes it easier for learners, CDC staff, and partners to offer and earn CE in one place. You can continue to use TCEO for existing activities that have CE set to expire in 2024, since these courses will not move to CDC Train. You may also use TCEO for existing activities with CE set to expire in 2025, before the courses transition to CDC Train. If you begin one of these courses in TCEO, we will let you know when the course will move to CDC Train. You can access and download CE transcripts and certificates in TCEO through the end of 2025. All continuing educations for COCA Call is issued online through CDC Train, and those who participated in today's live COCA Call and wish to receive continuing education, please complete the online evaluation and post-test before October 21, 2024, with the course code WC 4520R-091924. The registration code is COCA 091924. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation between October 22, 2024 and October 22, 2026, and use course code WD 4520R-091924. All of these instructions are available on our COCA Calls landing page at emergency.cdc.gov/COCA. Today's COCA Call will be available to view on demand a few hours after the live call at emergency.cdc.gov/COCA. A transcript and closed caption video will be available on demand on the COCA Calls webpage about a week after the live session. And you can visit emergency.cdc.gov/COCA for more details about this COCA Call and other upcoming COCA Calls. We invite you to subscribe to receive announcements for future COCA Calls by visiting emergency.cdc.gov/COCA/subscribe.asp. You will also receive other COCA products to help keep you informed about emerging and existing public health topics. Again, I want to thank you for joining us for today's COCA Call and have a great day.